Hello everyone, I am Dr. Harmeet Goel, your OBS Gynae faculty, and welcome you all to this rapid recap of OBS and Gynae session today for the upcoming INI-CET exam that is to be held in November 2023. So welcome you all to this live session, and I have tried my best to collect all the content which is very important based on the present pattern of the INI-CET exam, and it is covering last 3 to 4 years exam pattern. So in this session I have got some of the images, instruments, important questions, points, and tried my best to cover most of the topics in this rapid recap session. So let us just start. So I will keep on seeing your answers in the chat box. So my first slide is an image, and you have to identify. It is going to be an interactive session, not just teaching on one side, but solving your doubts and interaction with the students. So identify this image. What is this image? This image is of, like sterilization. So that is what is a hint I am giving it to you. So identify what is shown in this image. So I can see your chat. Welcome you all. So can you see this image? This is hysteroscope. Through hysteroscope, a coil is been introduced into the lumen of the fallopian tube, and this is assure. This is hysteroscopic sterilization. This is hysteroscopic sterilization, and this assure, what does it contains? It is made up of nitinol, that is an alloy containing nickel and titanium. Okay, so you have to remember the composition of assure as well. So assure, that is a type of hysteroscopic sterilization, has already been asked in one of the AIMS PG entrance exam, and it was repeated in one of the FMG exam as well. So what does it contain? This is a hysteroscopic sterilization, and this coil is been made of nitinol, that is an alloy comprising of nickel and titanium. So when this is been put or introduced into the lumen of the fallopian tube, it blocks the lumen and there is fibrosis. So for 3 months the couple has to use additional method of contraception. The couple has to use additional method of contraception. So that means the backup is required in this method of contraception for at least 3 months, and this permanently damages the fallopian tube. So after the 3 months there is no need for any additional method of contraception. Now this is blocking the lumen. It is blocking the lumen of the fallopian tube. So when the sperms are going to enter into the uterine cavity, because this lumen is blocked, it will not be able to enter into the fallopian tube, hence provide the sterilization. So this method is assure. Yes, I can read your answers. Chandrayan, Anshika, you have written it very correctly. Now proceeding to the next slide, you have to understand what is this shown in this particular image. This is the FIGO classification image for the types of fibroid. Now my question from you is, there are 0 to 7 types of fibroid. Okay, 0 to 7 types of fibroid, that is the category of fibroids. Now my question from you is that you have to tell me what are the types of fibroid that can be removed by hysteroscopy. So numbers given in this image are 0, 1, 2, 3, 4, 5, 6, 7 and 8. So till 8 is a cervical fibroid. Till 8, 0 to 8, these are the different varieties of fibroid that can be uterine or extrauterine fibroid. Uterine fibroid includes the intramural, submucosal and subserosal, and in the cervix there is fibroid. Extrauterine can be in the broad ligament. Okay. So you tell me what are the types of fibroid that can be removed by hysteroscopy. You can write down in the chat box. I am reading the chat. Now, answer to this question, the types of fibroid that can be removed by hysteroscopy, you can see if the hysteroscope is been introduced into the uterine cavity and under visualization. Okay, this is what is called as the therapeutic hysteroscopy, and the distending media used can be glycine, hiscon or any liquid media. Best is the glycine media. Now, through hysteroscopic guidance, you can remove the fibroid. So, what type of fibroids you can remove? Type 0, type 1 and to an extent type 2 can also be removed. Whereas type 2 fibroid, more than 50%, it is occupying the myometrium. Whereas type 0 is projecting into the uterine cavity, type 1 less than 50% in the myometrium, rest is projecting into the uterine cavity. Yes, I can read your answers very correctly. Dr. Nikita, Dr. Mrinal, Dr. Sabya, Dr. Subhash, Dr. Anshika, Dr. Amit, yes, all of you, Dr. Fareen, Dr. Sunil, yes, I can read your answers. Now, so 0, 1 are 100% removable, and to an extent type 2 fibroid can also be removed. Now, my next question is, what are the types of fibroid that can be removed by laparoscopy? Looking into the same image, you have to tell me the answer. Cervical fibroid will be difficult because it is not into the cavity, whereas hysteroscopy you are doing or visualizing the uterine cavity. So, more focus is on submucosal type of fibroid. Okay. So, I think Anshika, I have given your answer. It is not cervical fibroid, it is the submucosal fibroid that can be removed. Now, talking about laparoscopy, what are the types of fibroid? Naturally, it is the subserous fibroid that can be removed. So, what are your answers to this question? So, it is a quick recap and plenty of like slides I am going to discuss, that is based on important topics and looking at the last 3 years pattern of INI-CET exam. Yes, that is very correctly. So, it is type 7, type 6 and to an extent type 5 fibroid that can be removed by laparoscopy. Easily you can remove the type 7, type 6 and to an extent type 5 fibroid as well. Fine. So, hysteroscopy removes the submucosal fibroid and laparoscopy removes subserosal fibroid. Clear? Now, you have to tell me what are the drugs? What are the drugs that can reduce the size of fibroid? What are the drugs that can shrink the size of fibroid? you have to remember the progesterone, oral contraceptive pills, Mirena. These are the ones that is to treat the symptoms of fibroid, like example menorrhagia. Okay, but they do not shrink the size of the fibroid. So what are the drugs that shrinks the size of the fibroid? That includes ulipristal, even letrozole, danazole to an extent, R-486, but the best drug can be the GnRH analogues. GnRH analogues that can be agonist or antagonist. These are the drugs that can reduce the size of the fibroid. Fine. So, ulipristal, what is ulipristal? What is letrozole? Ulipristal is selective progesterone receptor modulator. Letrozole is acting as an anti-estrogen. Danazole is, like androgen derivative, but it acts as an anti-estrogen. R-486 is anti-progesterone, and GnRH analogues can be agonist or antagonist. Trexinamic acid that can be given to treat the symptoms. Okay. So let us proceed further with the slide. Now, they are very fond of asking the question on Mullerian duct anomalies. Very fond of asking the question on Mullerian duct anomalies. Now, I have given you a hint. You have to tell me the name of the Mullerian duct anomaly that can cause unilateral dysmenorrhea. That means on one side there is dysmenorrhea. Number 2, hint. This can be framed in the form of question, like there might be an HSG image or a laparoscopy or hysteroscopy image which is showing. Most of the time they give you an HSG image. Most of the time they give you an HSG image and they are asking a question. Now, you have to name the type of Mullerian duct anomalies that can cause unilateral dysmenorrhea. Also, this anomaly, there is a rare chance for ectopic pregnancy, and this anomaly which I am talking about belong to which class of Mullerian duct anomaly. Whenever you are solving a OBS and Gynae question, always there are many hints given in the question. It is for you to grasp the hint. Now, that is what I am creating this kind of slides, so that clear-cut view you should have and you should be able to answer. Now, the type of Mullerian duct anomaly which can cause unilateral dysmenorrhea on one side, or there can be a rare chance of ectopic pregnancy. This I am talking about is a unicornuate uterus. Unicornuate uterus. You know there are two Mullerian ducts. They fuse to form uterus, cervix and upper part of vagina and both sides the fallopian tubes, and the septum recanalization takes place by 20 weeks of pregnancy, and the lower vagina arises from urogenital sinus and upper vagina arises from Mullerian duct. So there is canalization of the vagina and there is canalization, or the septum of the uterus resolves. When there is any defect that leads to Mullerian duct anomalies like uterus didelphus, uterus bicornuate, arcuate, unicornuate uterus, etc. So unicornuate uterus, that means there is just from one horn the uterus, fallopian tube and cervix is developing, and another horn is just joined. If there is no communication with the uterine cavity and there is development of the endometrium, proliferation of the endometrium, but this blood is not been able to enter into the uterine cavity, leads to a condition that is called as unilateral dysmenorrhea. So this is a finding in unicornuate uterus. Number 2, if there is a communication with the uterine cavity, what will happen? There is fertilization of the ovum take place, and instead of going to the fundus, this fertilized ovum goes into the rudimentary horn of the uterus and leads to a rare chance of ectopic pregnancy, which can be at times dangerous. So these are the 2 things you must remember for unicornuate uterus, that it can cause unilateral dysmenorrhea, and number 2, there is a rare chance for ectopic pregnancy. If this rudimentary horn is communicating, there may be a chance of ectopic pregnancy. If it is non-communicating with the uterine cavity, there is a chance of unilateral dysmenorrhea. Okay. Next, this anomaly belongs to which class of Mullerian duct anomaly? So answer is class 2. Class 2. Does it have a good reproductive outcome? No, it has got a poor reproductive outcome. So you have guessed it very correctly, Dr. Anshika, Dr. Sabya. I can read your answers. Unicornuate uterus, you have marked it very correctly. So I hope this slide is very, very clear to you. Now this is an HSG image which has been asked in the previous INI-CET exam. Even it was asked in AIMS PG entrance exam as well, when the 4 institutes were taking their exams separately. So you can see this is an hysterosalpingography where there is a radio opaque dye like urographene which is put into the uterine cavity, and you can see, you can trace only one-sided and there is a fallopian tube. So this is unicornuate uterus. If it is not connected with the uterine cavity, then there can be unilateral dysmenorrhea. If it gets connected, then there may be a chance for ectopic pregnancy, which I have already explained. Next, so class of Mullerian duct anomalies. Class 1 is Mullerian agenesis or hypoplasia. Number 2 is unicornuate. Number 3 is uterus didelphus, where there are 2 uterus, 2 fallopian tubes, 2 cervix. Okay. Then bicornuate uterus. Number 5 is a septate uterus. Number 6 is arcuate, and number 7 is DES related. Now, which type of Mullerian duct anomaly is the most common Mullerian duct anomaly? Which is the most common type of Mullerian duct anomaly? What's your answer? You can write down in the chat box. Okay. Dr. Raghav, I am just going to tell you the difference between septate and bicornuate uterus as you have written in the chat. So most common type of Mullerian duct anomaly is always, like septate uterus, and then next is the bicornuate uterus. Now Mullerian duct anomalies, when you are going to operate only if it is causing habitual abortion, that means more than 3 abortions in a sequence, or it is a cause of infertility, provided that other causes of infertility you have ruled out. Then only then in that case you are going to operate the Mullerian duct anomalies. Now, if you see the HSG image of the septate uterus and bicornuate uterus, it is, it looks like almost similar kind of thing. But the differentiating feature is that this angle between the 2 horns or the cornua, this is an acute angle. It is less than 90 degrees. Whereas in bicornuate uterus, this is septate. This is more than 90 degrees. So that is one differentiating feature between the septate uterus and bicornuate uterus. Now, Next differentiating feature, you have to go for the gold standard investigation. Now, what is the gold standard investigation? You have to do a hysteroscopy plus laparoscopy. You have to go for hysteroscopy plus laparoscopy. With hysteroscopy, you can diagnose and treat the septate uterus. With laparoscopy, you can confirm your diagnosis and treatment for the bicornuate uterus. So, HSG is a preliminary investigation, which is an important investigation. When you are dealing with an infertility case, you might find Mullerian duct anomaly, which can be a septate or bicornuate. Now, confirmatory will be the laparoscopy or hysteroscopy, or if you want to go for a non-invasive investigation, then it can be a 3D ultrasound or an MRI scan, which is non-invasive. Nowadays, 3D ultrasound is done more commonly than the MRI scan. So, with hysteroscopy, if there is a septum, you do hysteroscopy, you visualize it, and you can resect out the septum. Okay. When it is a bicornuate uterus, you do a laparoscopy. Okay. And with laparoscopy, you resect out this portion and you just stitch that. This is called as metroplasty. That can be done by laparoscopy. So, for septate uterus, the treatment is hysteroscopy. For bicornuate uterus, you can do laparoscopic guided metroplasty. Yes, Dr. Anshika, you are very correct. Yes, Dr. Anshika, you are writing very correct answers in the chat box. Yes. See, ultrasound is a very basic investigation. We usually do not depend upon the ultrasound finding. Either it is HSG, needs to be confirmed on hysteroscopy or laparoscopy. So, the septum can be removed. Whatever is the problem in the uterine cavity, that can be removed by hysteroscopy, and if it is like bicornuate uterus, then resection and reuniting can be done. That is called as metroplasty by the laparoscopy. Fine. Now, which of the following Mullerian duct anomalies the reproductive outcome is very good? Answer is, or arcuate uterus has got a very good reproductive outcome. And next one is the uterus didelphus. Fine. So, let us proceed with the next part. Now, the type of tubectomy method where there is no chance for recanalization, I have given you the 4 options. What do you think can be the correct answer? The type of tubectomy method where there is no chance for recanalization. The answer will be fimbriectomy. Okay. Now, why do I say fimbriectomy? Now, the most popular or most commonly done tubectomy method is the Pomeroy's technique, where you make a loop and you ligate it and you cut it, okay, and send it for histopathological examination. Fine. So, if you have cut the fimbrial end, fimbria do not regenerate. So, there is no chance for recanalization. A similar question has already been asked in one of the exam. So, you are asked to identify the image, so you can know. In one of the exam, they have asked, name the method for fimbriectomy, then answer is Kroner's fimbriectomy. So, if you have cut the fimbria, do fimbria regenerate? On both the sides you have cut the fimbria. Can fimbria regenerate? No. Now, role of fimbria is it pick up the ovum, and ovum is like traveling into the lumen of the fallopian tube, where the fertilization take place in the ampulla. So fimbria cannot regenerate, so there is no chance for recanalization. Fine. Now, I hope I have made this very, very clear. Now, since we are talking about recanalization, you have to tell me how much length should be left, how much length of the fallopian tube should be there when recanalization is possible. Minimum length, recanalization is possible. Minimum length of the fallopian tube where the chances of recanalization are possible. So the answer is minimum length should be at least 4 centimeter. The chances of recanalization is possible. Fine. See, there are many techniques, but we are using only the Pomeroy's technique. The other techniques include the Irving's method, Medliner's, Parkland. Okay, in Medliner you can see there is a loop and the base of the fallopian tube, this is like crushed, and this ligature is being used, that is the silk ligature. Fine. Now in cases of Irving's method, Irving's, the one end of the tube is buried posteriorly into the uterus and another end is ligated. Now if you talk about the Parkland, there is a wedge shaped resection of the fallopian tubes, but most of the time they ask about the Pomeroy's technique, or they ask about the like the name or identify the image, what is the type of method, you have to name the methods. Now in one of the exam they have asked this image. Now what is this image number 1? What is this image number 1? You can write the answer in the chat box. I have asked you what is this image number 1, what is the name of this instrument? What is the name of this instrument? This instrument is called as laprocator. Laprocator, and these are the prongs. These are the prongs, and this is the press button. So when you are doing laparoscopy, you introduce the laprocator and there are the fallope rings. These are the fallope rings which is made of silastic material. Fallope rings which is made of silastic material, and when you identify the fallopian tube, you have to identify trace till the fimbrial end. Trace till the fimbrial end, and this one is the round ligament. So specially I am showing you this image so that you can understand that this is round ligament. Round ligament you cannot trace till end, but the fallopian tube you can trace it till the end, and below that you can see a pearly white structure, that is the ovary. This is the uterus. And can you see, can you appreciate the white color of ring? This is a fallope ring which has been applied. So this is laparoscopic sterilization. Laparoscopic sterilization. Okay. So this ring, this loop has been made, and which part of the fallopian tube is it ligated, whether you are doing postpartum sterilization or interval ligation or you are doing laparoscopic sterilization, it is the isthmic part of the fallopian tube. Isthmic part of the fallopian tube that is been ligated. Okay, it is the isthmic part of the fallopian tube which has been ligated. Fine. So this is a laprocator. Remember, whenever you see the prongs, that is a laprocator, and this is a very fine laparoscope, which is the term is called as the laprocator, and this is for laparoscopic sterilization. In our country we are doing it with the fallope rings, although clips can also be applied. Previously cautery was done, but cautery used to cause permanent damage to the fallopian tube, so there was no chance for recanalization. But if fallope rings is applied or clips is being applied, recanalization can be done. Now what is this instrument? What is this instrument? This is called as carbon dioxide insufflator. Carbon dioxide insufflator. This session is going to be useful for the NEET PG exam as well. Okay, because there are image based questions in the NEET PG exam as well. So this is carbon dioxide insufflator. Around 1 to 2 liters of carbon dioxide is insufflated, that will cause pneumoperitoneum. What is the intra-abdominal pressure? What is the intra-abdominal pressure in laparoscopic sterilization or when you are creating a pneumoperitoneum? The intra-abdominal pressure is 10 to 12 millimeters of mercury. So many questions I have just told you in this image. You have to identify, this is laprocator, this is prongs, fallope rings, this is carbon dioxide insufflator, and the amount of gas is 1 to 2 liters, and intra-abdominal pressure is 10 to 12 millimeters of mercury. Okay, which part of the fallopian tube is to be ligated? That is the isthmic part of the fallopian tube has to be ligated. Okay, so I can read your answers in the chat box. Dr. Ravi, Dr. Yash, Dr. Raghav, yes, you are absolutely correct. Dr. Aniket. Now you have to identify this image. This has been asked in many exams. It's not that all the questions and all the slides are image based questions or images I am discussing. No, I am discussing every important content, because OBS Gynae is a subject where you can score maximum marks in among the clinicals. Okay, and it's not very difficult, provided that your concepts are clear. If there is a long question, definitely 100% you can mark it correctly. Okay, clinical question, in clinical scenarios there are lot many hints in the questions, you can correlate and mark the answers correctly. Now this has already been asked. Now what is this image? Yes, Dr. Anshika, you are very correct and you are very fast in answering. I appreciate your presence in this session, and others too are writing very correct answers. Yes, this is the Babcock's forceps. Babcock's. You have to identify. So that is why I have just taken this image, so that you can clearly understand that this ends of this, which is made like this fenestrations. Why? Because it is used to hold the tubular structures. It is used to hold the tubular structures like fallopian tubes, like ureters, etc. Okay, so this is used in tubal ligation method, like we are holding the tube for sterilization, that is by the Pomeroy's method. You are holding the fallopian tube, okay, and then you are doing the ligation. It is also being used by the surgeons to hold the ureters, okay, while doing the surgery. So I hope this is very clear to you. This is Babcock's forceps. Okay, so I proceed with the next slide. Then postcoital contraception is again very important point to be discussed here. Postcoital contraception is emergency contraception, and another name for postcoital contraception is interceptives. Okay, it is used in those couples who had unprotected coitus or failure of contraception, like condom failure, misplaced IUCDs or missed pill, etc., or in the rape victims, which is very unfortunate. So that is what is the role of emergency contraception. So emergency contraception or post-coital contraception, it can be hormonal, within 72 hours of unprotected coitus, or it can be IUCD within 5 days of unprotected coitus. Okay. Now my question from you is, which type of IUCD can be used in postcoital contraception or emergency contraception? Which type of IUCD can be used in emergency contraception? It is the copper IUCD or copper T. Mind it, Mirena is not an emergency contraception. Fine. Now among the hormonal, it is LNG pill which they have asked, that is what the dose is 1.5 milligram single dose. Number 2 is oral contraceptive pills, 4 tablets, and after a gap of 12 hours 4 tablets, and number 3 RU486. These are the 3 drugs which can be used. Yes, you are very correct. Okay, so Mirena is not an emergency contraception. There is one more drug that is called as ulipristal. Ulipristal, the dose is 30 milligram and single dose. It is to be given within 5 days of unprotected coitus, but in India availability is a problem. So what is ulipristal? Ulipristal is selective progesterone receptor modulator. Okay, remember there are only 2 uses of ulipristal. Number 1 is postcoital pill, and number 2, it is given for 6 months in the fibroid. After 6 months 50% reduction in the size of the fibroid is done, is seen. That is 5 milligram daily to be given for 6 months, and it reduces the size of the fibroid. So 2 uses, remember, for ulipristal. Ulipristal is selective progesterone receptor modulator. It's a postcoital pill to be given within 5 days of unprotected coitus, and it can be given in fibroid. It shrinks the size of the fibroid. Okay. Now mechanism of action of emergency contraception: it can delay ovulation, it can inhibit implantation, but remember, it is never any abortifacient. Okay, so it does not cause any abortion. If the pregnancy has resulted, then there is no role of these postcoital contraceptives. Fine. Now which is the best postcoital contraception? Best postcoital contraception is what you are going to mark. It is always copper T is the best emergency contraception. What is most commonly used emergency contraception in India? Answer is LNG pill, 1.5 milligram single dose. So most commonly used emergency contraception in India is LNG pill, and best postcoital contraception is always copper T. Okay, so I hope the important concepts of contraception is clear. Then OCPs, IUCDs, temporary contraceptives, others you should read, all that is important, but these are the topics which are very frequently or commonly asked from the topic of contraception. Fine. Now just tell me, what are LARC contraceptives? LARC means long acting reversible contraceptive. Long acting reversible contraceptive, and there are 3 category of contraception in them. What are they? What are they? LARC contraceptives. Number 1, it is IUCD. Number 2, it is injectables like DMPA injection, which is available in the form of Antra in the government supply. Okay, and number 3 is subdermal implants. So this is very important, because so many students get confused What are the LARC contraceptives? It is IUCDs, it is injectables, and it is subdermal implants. Okay. Now, one more question. What is the preferred contraceptive in cases of epilepsy and sickle cell anemia? Because OCPs cannot be given. So, in sickle cell anemia, in epilepsy, what can be the type of contraceptives you can give? So, the answer to this question is DMPA injection. DMPA injections can be used in these conditions. Fine. Next. Now, let us take up something from disorders of menstruation topic that is very, very important, and this one question I have taken it from INI-CET exam. Okay, this will solve many of the part. Okay, now one important thing I want to tell you, that like the mechanism of action of these contraceptives is suppression of ovulation, okay, except the IUCDs. Okay, so the subdermal implants, which is Implanon, that contains 68 milligram of etonorgestrel. Okay, so this causes suppression of ovulation, and Implanon do not decrease the bone mineral density. That is what is the advantage. Fine. Now, coming to this question of disorders of menstruation, now analyze the hormonal profile of a 25-year-old women presented with amenorrhea. Okay, so you have to match this. This is very, very important. Okay, so this is what is the format of questions, just because many of you might be writing the INI-CET exam for the first time. So, just to tell you, to make the things clear, that they are giving some questions in the form of match the following, and then there are some options which is the correct one. Okay, so let me start with Asherman syndrome, because everybody knows the hypothalamus, pituitary, ovary, everything is normal. Pituitary ovary secretes its hormone normally, FSH, LH normal, estrogen, progesterone normal, but the problem is at the end organ. The defect is at the end organ. There is synechiae formation or adhesions between anterior and posterior wall of the uterus. So that is why there is secondary amenorrhea, because of vigorous curettage performed at DNC or MTP. Fine. So hormonal levels are normal in cases of Asherman syndrome. So Asherman syndrome, the match is 2. Okay, FSH, LH, estradiol, all normal. Then premature ovarian failure, there is depletion of the ovarian follicles less than 40 years of age. So the estradiol levels are down, and there is no negative feedback at the level of pituitary. So FSH, LH is high. So it goes for number 1. FSH, LH is high and estradiol is down. Sheehan syndrome is postpartum pituitary necrosis. So FSH, LH, estradiol all are down, and PCOS is number 4. That is, A is 4, B is 2, C is 1, and D is 3. So this is the correct. So you should be able to solve this, okay, very, very correctly. These are the questions which should not be missed out. They have asked the tumor markers, they have asked the steps of the pap smear, that what is the sequence of the steps. Then in some other questions also they have been asking match the following, like in the maneuvers also they have asked a question. So just to give you a clear cut idea, I am just discussing these some selective set of questions. Okay, so these are the questions. The most easy one I am thinking not in terms of a teacher, okay, like I have been taking classes for so many years just because it's easy for me. No, I have discussed this question from the student point of view, how you should be able, just to tell you the tricks, how you can make the OBS Gynae subject as your strongest subject where you can get full out of full marks. So select the one which you know it perfectly. Like some students have a confusion in PCOS. So start with Asherman syndrome, start with premature ovarian failure, because you know what is the concept in premature ovarian failure. The ovarian follicles get depleted, so estradiol has to be down because there is no ovulation. Okay, so negative feedback inhibition is not there. So you know gonadotropins, FSH, LH has to be elevated, and you know like the estrogen levels has to be down. Hence from the pituitary the hormones are down, so the ovaries are not stimulated. Fine. Now I am proceeding with the next part. Okay, identify what is this. What do you see in this image? What do you see in this image? This is a laparoscopy image. This is a laparoscopy image. No, this is not chocolate cyst. Yes, Dr. Fareen is right, Dr. Ganguly is right. No, Dr. Joshi, this is not endometriosis. Yes, Dr. Raghav is very right. No, this is not powder burn. This is laparoscopy showing ovarian drilling. This is usually done in cases of infertility, and in infertility when you are doing laparoscopy. Okay, if you find endometriosis, then you do the adhesiolysis in endometriosis. Okay, if you find polycystic ovarian disease, multiple cysts in the ovaries, you can plan an ovarian drilling. You can plan an ovarian drilling. So ovarian drilling, how does it work? In ovarian drilling, this cysts contains increased androgen. When you are doing ovarian drilling, the fluid comes out, so androgen levels, these fluid in the polycystic ovaries are rich in androgens. So androgen levels goes down, and when androgen level goes down, automatically the ovarian function improves. Automatically the ovarian function improves. Okay, so that is what is the idea of doing ovarian drilling. But ovarian drilling, even if it is an infertility case, is not the first choice. First choice is always the medical management. Always, if it is infertility, you are going to give the drugs. Preferred drug is letrozole, then clomiphene citrate nowadays. And if the female is not able to conceive after letrozole or the clomiphene citrate, you can switch over to the next line of drugs, that is human menopausal gonadotropin injections, that is FSH injection. Okay, I hope this is clear to you. Now, I have taken up one of the question of INI-CET just to give you a clear-cut idea what is the way that they are asking questions. Definitely they are not going to ask, bachon batao, what is the most common cause of hirsutism and menstrual disturbance. Of course, they are not going to ask you that way. Okay, so just to show you how they are asking a question, a 16-year-old girl presents with infrequent and prolonged cycles, image is given. An ultrasound was done showing bulky enlarged ovaries. FSH is 3.5, LH is 21, TSH is 7.5, and what will you give to manage her? Now, what do you see in this image? You can see clear cut that there is hirsutism. You can see clear cut this is hirsutism. So, hirsutism plus menstrual disturbance and deranged LH to FSH ratio. These are the three things which has been given in this question. So definitely your diagnosis is PCOS, polycystic ovarian syndrome. Okay, definitely the diagnosis. Letrozole, Dr. Raghav, the dose of letrozole you are asking. Letrozole is aromatase inhibitor. Aromatase inhibitor, and it decreases the estrogen levels so as to increase the FSH level, so follicular maturation starts. Okay, so follicular maturation starts. Now dose of letrozole is 2.5 to 10 milligram. You can start with 2.5 and it is given from day to day 6 of the cycle. Okay. See here the TSH levels is been given because like the like pigmentation and menstrual disturbance, the cause can be the thyroid disorders as well. So that is also given, but like clear cut here from this image and from the question it is PCOS. Fine. Now the question, the options given to me here are, what are you going to, matlab this is a 16-year-old girl and you have picked up from the question she is having PCOS. Okay, you can try giving letrozole or clomiphene citrate at least for 3 cycles you can give. Maybe you can extend to the 6 cycles depending upon the age of the patient. If suppose she has been married at 37 years and all, so you don't have much of the time, you can give 3 cycles, and if she is not able to conceive, you try to rule out other causes of infertility as well, because 40 to 50% cases of infertility, there can be an associated problem of endometriosis where there can be adhesions. Okay, so that is why you can you can offer her the next line of management if only the ovulation induction does not work. Suppose if it is a 25-year-old female where she is young, okay, then you can try giving her like ovulation induction with letrozole or with the clomiphene citrate for at least 6 cycles before you switch over to the next plan of management. So that is how it varies from case to case and age of the patient. Fine. Now you have to tell me this answer. Now I hope it's clear. You don't want me to skip out the slides, because I just want to help the students, those who are attending this session and later on those who are going to watch, that this is the type of questions they are asking and you should not make a single mistake in attempting these questions very correctly. So what do you offer to this young female who is unmarried girl? Lifestyle modification, that is first step. How does lifestyle modification helps? 2-3 times this part has been asked in your exams. Okay. Lifestyle modification, that means exercise, brisk walking, taking healthy diet, avoiding junk, fatty food, etc. So that is what is a lifestyle modification. It will decrease the androgen levels and it will reduce the insulin resistance, and automatically the ovarian cycle will improve. That is always your first step, weight reduction and lifestyle modification. The next line of drug is the next line of management is the drugs. OCPs is a wonderful drug. It is a preferred drug because it will regularize the cycles. And third, you can offer her anti-androgens, like to treat the hirsutism part. Laparoscopic ovarian drilling has got no role in this particular case. Yes. Dr. Alo, you are absolutely correct. Dr. KK, you are correct. Dr. Sovik, Dr. Mrinal, Dr. Farheen, you have answered very correctly. So answer is 1, A, B, C. I am going to offer not the laparoscopic ovarian drilling. Okay. Now let us proceed with the next part. Next, my question, this is a very favorite part of INI-CET exam. They are very fond of asking about SRY gene. Okay, so just tell me, SRY gene is located on long arm of Y chromosome, short arm of Y chromosome. I hope every one of you know what is this SRY gene. This is sex determining region. This is sex determining region, and this is present in the Y chromosome, you should know. Now, is it present on the short arm or the long arm? Yes, Dr. Anshika marked it correctly, Dr. Mrinal, Dr. Fareen, Dr. Sovik, Dr. Devnath, I can read, Dr. Alo, I can read your answers. This is very correct. This is short arm of Y chromosome. Okay, short arm of Y chromosome, that is distal part of short arm of Y chromosome. Distal part of short arm of Y chromosome. Dr. Prashant, you have also written it correctly. Dr. Karthik, Dr. Chandriyan, Dr. Prashant, Dr. Raghav, all of you are correct. Okay. Now, this is what it should be. This I have added this image so as to make it an impression in your mind. Please always remember that it is on the short arm of Y chromosome, sex determining region of Y chromosome. Fine. Now, very important question, treatment of infertility in Swyer syndrome. That's a very favorite question of INI-CET exam. Previously, the AIMS PG and in the PGI Chandigarh entrance exam, they have asked this question. Treatment of infertility in Swyer syndrome. I hope you know Swyer syndrome is a type of male pseudo hermaphrodite. It's a type of male pseudo hermaphrodite. Okay, and genotype is a female. It's a flat female with no development of the breast. Sorry, genotype is a male and phenotype is a female. Okay. Yes, you are writing correctly the treatment part, but I am asking you what is the treatment of infertility in Swyer syndrome. Let me explain it, then it will be very clear. The treatment of infertility in Swyer syndrome, if you want to revise in single liner, then the answer is IVF using donor oocytes. IVF using donor oocytes. No, surrogacy is not needed because these patients are having uterus. Okay, they are having uterus. So it is IVF using donor oocytes. Fine. Now, what is this Swyer syndrome? This is gonadal dysgenesis. Okay, phenotype is a female and genotype is a male, 46XY. Okay, so there is inactivation of SRY gene, this genetic gonads are there. So it is a flat female with no breast development. Okay, she knows that she is a female because external genitalia is a female and there is undescended testis on ultrasound. Undescended testis. Okay, so these are streak gonads, undescended testis. Okay, and when you do an ultrasound in them, you know that uterus, cervix, fallopian tube are present, but gonads in them are testis. Karyotype is 46XY. So in these patients, the testis has Sertoli cells. So it has produced, but Sertoli cells are not functioning. They have Leydig cells. but again Leydig cells are not functioning, so there is no testosterone. So that is why external genitalia is female, and there is no anti-Mullerian hormone, so there is Mullerian duct derivatives present. In them, they have primary amenorrhea. Okay, so treatment in them has to be gonadectomy after the puberty is attained, because there is risk of cancer, testicular tumors. Okay, risk of testicular tumors, so gonadectomy has to be done. So remember, this is a flat female, no breast development, but external genitalia female. So patient has reared up as a female. So what happened? There are streak gonads, undescended testis, which the Leydig and Sertoli cells do not function. So Mullerian duct derivatives have formed uterus, cervix, fallopian tube and upper part of vagina. Okay, and testosterone was not produced, so Wolffian duct has regressed and external genitalia formed is the female. So you do gonadectomy and you give them estrogen followed by progesterone. When you have given estrogen, the breast development starts and proper feminine body figure. Okay. Now, when you give estrogen, there is proliferation of endometrium. When you give progesterone, there are secretory changes and then shedding of the endometrium occurs. So they start menstruating. Now, when they get married, they have infertility because ovaries are not there. Okay. So what you do is you give them estrogen plus progesterone, so that endometrial lining is being formed, and with the donor oocytes you can do IVF using the husband's sperms, and now embryos are ready, so you can transplant the embryos, and the pregnancy support can be done by the artificial hormones. So what is the treatment of infertility in single line is IVF using donor oocytes. Swyer syndrome is a cause of primary amenorrhea. It's a cause of male pseudohermaphrodite. There are streak testis, streak gonads. So the testis is not functioning. Sertoli cells, Leydig cells do not function. So no hormonal secretion. Hence, in these patients, because ovaries are not there, so female hormone is not there. Okay. So karyotype is 46XY. Patient has grown up as a female with no breast development at the time of puberty. Fine. So gonadectomy is the treatment to save the patient from testicular tumors. Then you can treat primary amenorrhea by giving estrogen and progesterone. Once the patient gets married, okay, proper counseling has to be done, and treatment of infertility is IVF using donor oocytes. Okay. So I have tried my best not to discuss just 2-3 topics, but to cover up all the important topics in the form of the questions, in the form of concepts, in the form of images, in the form of single liners. So at the end of the session, it is going to be fruitful, that I can promise. Fine. Thank you so much, Dr. Chandrayan, for appreciating the session. Thank you, Dr. Raghav, Dr. Pandya, Dr. Khan. Thank you for your wonderful words of appreciation. So let me proceed further. Now I come down to the infertility, and I am not here just to discuss, like about azoospermia, like to discuss, semen analysis. But I have just targeted one specific semen analysis report. Okay. This is the semen analysis report, which is showing azoospermia, low volume, acidic pH and absent fructose. I am striking at a higher level now, okay, because we are just not preparing for just a basic exam, just a central institute exam, which is INI-CET. Okay. So my sessions are very much target oriented, so as to cover up all the important concepts for INI-CET exam. Definitely it is going to help you for those who are going to write the NEET PG exam. I am going to bring out such exciting session for the NEET PG preparation as well. Okay. So please just tell me, what do you get it from this information? From this information, I can find out that either the seminal vesicles are absent, or that is called as congenital absence of seminal vesicles, where cystic fibrosis is a suspect, or there is obstruction where seminal vesicle is not able to enter its fluid into the semen. So that is why absent fructose acidic pH, because normally the pH of the semen is alkaline and there is fructose present. Presence of fructose is confirmatory for the seminal vesicles. Okay. Yes, Dr. Anshika, you have written it very correctly. Seminal vesicles absent or ejaculatory duct obstruction, very correct. Fructose is present, that means seminal vesicles are functioning, but this semen analysis report shows either it is ejaculatory duct obstruction. For that we can do transrectal ultrasound, or there is bilateral congenital absence of CAVD, that is bilateral congenital absence of vas difference and seminal vesicles, which is a feature of cystic fibrosis that you read in medicine or pathology, or there is retrograde ejaculation. Okay. So this is a finding of this. So this is what is the differential diagnosis for all this. Fine. Now, I hope you remember the WHO cutoff limit for semen analysis. Okay. So I hope you know it. What is the amount, count, motility, morphology. Cutoff amount is 1.5 ml, count is 15 million per ml, motility is 40%, progressive motility is 32% and morphology is 4%. Now recently asked question of INI-CET, what is the cutoff value of morphology in semen analysis? The answer is 4%. Cutoff value for semen analysis is just 4%. Now, what is the most important fertility indicator in semen analysis? Most important fertility indicator in semen analysis? Answer is morphology. This is very important. It has been asked in AIMS PG exam as well. Okay. Most important fertility indicator is always morphology. If morphology is not given, your answer changes to motility and then count. So most important fertility indicator in semen analysis is morphology of the sperm should be normal. Fine. Next. Now AMH. AMH is the best test for ovarian reserve. You know why. Why AMH? Anti-Mullerian hormone. Now anti-Mullerian hormone is secreted by granulosa cells, and in the males it is been secreted by Sertoli cells. Okay. So in the females it is secreted by granulosa cells, and this is the best test for ovarian reserve that you have to mark. Okay. Why? Because its value is not affected by feedback inhibition at the level of pituitary, and it can be done any time in the cycle. If its value is less than 1 nanogram per ml, then that is consistent with poor ovarian reserve. Poor ovarian reserve. Fine. So I hope this is clear to you. Yes, morphology disturbed is teratozoospermia. Very correct. Now identify this image, and I think it's clearly written in this image. This is an HSG image which is showing bilateral proximal tubal block. This is an HSG image which is showing bilateral proximal tubal block. Okay. Now my question is, what is the most common cause for proximal tubal block? Most common cause for proximal tubal block, what will you mark? The answer is physiological. There is physiological spasm at the cornua, physiological spasm. If you get such a finding, what will be your next step? This is very commonly asked question in the PG entrance exams. What is the next step? If you get such an image on HSG, what is your next step? Next step is always hysteroscopic guided cannulation. Hysteroscopic guided cannulation followed by laparoscopic chromotubation. Followed by laparoscopic chromotubation, because that will differentiate it is a physiological spasm or it is pathological. Okay, so it will differentiate physiological from pathological. So hysteroscopic cannulation, with hysteroscopy you are just diverting the wire through the cornua or the tubal ostia, and that wire is being directed. Okay, cannulation, this is called as hysteroscopic cannulation through the fallopian tube, and then you inject a methylene blue dye. Okay, and you can do the tubal patency test, that is called as laparoscopic chromotubation. Why laparoscopy is been added? Because when you are putting a dye, you want to see that now the tube lumen is open and that dye will be seen through the femoral end into the peritoneal cavity. That can be checked by the laparoscopy. So again I am repeating, if you get an image on HSG, hysterosalpingography, that is proximal tubal block, most common cause is physiological tubal spasm. So what is the next step? Next step is hysteroscopic guided tubal cannulation followed by laparoscopic chromotubation in the same setting. Okay, that will differentiate a physiological spasm from pathological. Even if there is a minimal, like tubal block, that can be corrected by hysteroscopic cannulation. So I hope I have made myself very clear in this. So this is the image which is showing laparoscopic guided catheterization, and this is hysteroscopic catheterization. And this blue you can see, that is the methylene blue dye. Fine. So this is hysteroscopic guided cannulation, you can see. Fine. In these images, this is just to clear out your concept. That is why I have added up the images in this session. Fine. Now let us proceed further. This is a very common mistake the students make. Let me tell you, this was a UPSC exam question, UPSC CMS exam. Okay, that is medical officer exam. Similar question has been asked in FMG, AIMS PG, NEET PG and DNB. Okay, and many students make this mistake. Chromotubation means you are putting a methylene blue dye into the uterus, dye entering into the fallopian tube from a femoral end. There is a blue dye in the peritoneal cavity, that you can see via laparoscopy. Okay. Now a couple came to infertility clinic, semen analysis was done, it is normal, ovulation study is normal, and ultrasound shows, hysterosalpingography showed bilateral tubal block. What is your next line of management? I am very happy with this present batch of students, Dr. Anushka, Dr. Bobby, Dr. Sovik, Dr. Alo. You have written it very correctly. Whenever there is an HSG, HSG is always a preliminary investigation. Always you need to confirm it on laparoscopy. Never you just mark your answer as tuboplasty or IVF. Let us confirm first. So the best confirmatory investigation after a tubal block is always laparoscopy, and you combine it with chromotubation. Okay, never ever write your answer as tuboplasty or IVF. Okay, that will be wrong answer, because HSG, do you think it is confirmatory? No, it is not confirmatory. Laparoscopic chromotubation is a confirmatory investigation. So I am happy that all the students who is just attending this session, They are all marking it very correctly. Dr. Chandriyan, Dr. Yashpal, Dr. Mrinal, Dr. Fardeen, all of you are absolutely correct 100%. So, shall I say that Obs Gynae is your favorite subject, or shall I say that like you are attending my session, or shall I say that you have made your preparation of Obs Gynae the perfect? That's why you are all writing the very correct answers. I am happy, Dr. Patel, with your comment. Identify this investigation. What is this? What is this image showing? I like your smileys, Dr. Chandriyan. Now, what is this image showing, students? Yes, Dr. Sovik, Dr. Khan, Dr. Karthik, everybody is writing very correctly. This is ICSI, intracytoplasmic sperm injection. Okay. Now, ICSI has replaced IVF in most of the settings nowadays. Okay. This is better than in vitro fertilization. The success rate is very good, better than IVF, and like it can be offered to those males who have obstructive azoospermia and they don't want to go for surgery. They just want the treatment of infertility. In that case, sperm retrieval can be done by using the TACE techniques, okay, or TESA techniques, that is testicular sperm extraction or testicular sperm aspiration, or PESA techniques, that is percutaneous epididymal sperm aspiration, whatever techniques you are following. So it is a very good like offer to those who have got severe oligospermia, that means sperm count less than 5 million per ml. It's a very good options for those who have got teratospermia, azoospermia, asthenospermia, and for those who have got unexplained infertility. So it's a very, very good options, ICSI, intracytoplasmic sperm injection. Fine. Now, let us proceed with the next part, that is endometriosis. Okay. So what is a triad for endometriosis? Triad, quickly. Now I will be doing quickly the gynae part, and I will be switching over because most of the part in detail I have discussed, whatever is the all important points and topics about the gynae. So triad of endometriosis, which is correct? This is very, very favorite question of exams. Dysmenorrhea, infertility, dyspareunia, menorrhagia, pain, infertility, menorrhagia, hematuria, or dyspareunia. What's your answer? Yes, very good, excellent batch. This is dysmenorrhea, infertility, and dyspareunia. That is a classical triad of presentation of endometriosis. Now, what is the most common symptom of endometriosis? This is very favorite question. Answer is, it is always pain. Pain of congestive dysmenorrhea or pain due to adhesions. Another presentation of endometriosis can be infertility. Another presentation of endometriosis can be an adnexal mass. So these are the three types of presentations for endometriosis patients. So accordingly, you will offer the treatment. Pain, infertility, adnexal mass, dyspareunia, or menstrual disturbance. Now, what is this image? You can see this is a laparoscopy image signifying endometriosis because you can see the adhesions. You can see the adhesions. Yes. Dance India dance. Yes, good. So this is adhesions, and fallopian tube is entangled in adhesions. Fimbria is not covering the ovaries. You can see the chocolate cyst of ovary. chocolate cyst of ovary, peritubal pouch of Douglas adhesions. So this is almost severe form of endometriosis. Now, why there is infertility in endometriosis? Because of immobilization of fallopian tube due to adhesions, because of distorted anatomy, because of the inflammatory mediators, etc. So, all these are responsible for infertility. And remember, 40 to 50% cases of unexplained infertility, the cause is endometriosis. So, most of the cases, the gold standard investigation in this case is always laparoscopy. The gold standard investigation in this case is laparoscopy. Fine. Now, treatment of pain, you can give medical treatment in the form of NSAIDs, progesterone, OCPs. For the surgery, you can do laparoscopic adhesiolysis. And remember, if it is infertility, you can do mild endometriosis, the ovulation induction. And for moderate to severe, you can treat by IVF, because you can see when you try to break these adhesions, you can cause more complications. So if the patient's concern is just to treat infertility, it's better you can offer IVF to these patients. Fine. Now, identify what do you see in this. Okay, I have given you multiple images in this. What do you see? I have given you an ultrasound image, I have given you a Doppler image, and I am showing the specimen. Okay, then I will tell you what type of questions are being asked on this. I will just let you know what type of questions are being asked on this. What do you see this? Friends, this is endometrial polyp. It presents with intermenstrual bleeding. Intermenstrual bleeding, in between the periods there is bleeding. And the third hint in the question is a feeder vessel sign on Doppler. If you get a question, the patient is around 43, 44, 45-year-old female who presented with intermenstrual bleeding, and an image like this is given. This is endometrial polyp with a narrow base, or there is a feeder vessel sign or fetal vessel sign written in the question. This is another hint. Okay, hint. Intermenstrual bleeding, feeder vessel sign, Doppler ultrasound image or an ultrasound image or a specimen. You can see this is endometrial polyp, which can present as a postmenopausal bleeding or intermenstrual bleeding. And the gold standard or treatment for this is hysteroscopic guided polypectomy, and send that sample for histopathology. So endometrial polyp on hysteroscopy also they have asked an image in the AIMS PG exam. Okay, so I hope this slide is very clear. Ultrasound image, Doppler image, specimen image, question, that is intermenstrual bleeding with a feeder vessel sign and image, okay, and hysteroscopic polypectomy. Fine. Now, 43-year-old female with intermenstrual bleeding and feeder vessel sign, it has to be an endometrial polyp. Next, this is again a question of NEET PG pattern, and from the image what do you see? This is ovarian hyperstimulation syndrome, okay, because patient is a case of infertility and it has shown anovulation and HMG injection was given. She developed pain, distension, dyspnea, and ultrasound showed this image. This is, friends, not polycystic ovarian disease, it is ovarian hyperstimulation syndrome. Fine. Now, this is again very interesting. They give you an image based question like this. A female presented in the OPD with vaginal discharge, and this image is given. Can you tell me the causative agent and diagnosis for this? Causative agent and diagnosis for this image. What do you see in this image? This is a clue cell. Clue cell means epithelial cell where bacteria get adherent. Epithelial cell where bacteria get adherent. So what is this? This is an image of Gardnerella, that is the causative agent for bacterial vaginosis. Bacterial vaginosis is very favorite question for INI-CET pattern of exam. Previously such questions were asked in AIMS PG. So from the topic of vaginal discharge, do expect a question on bacterial vaginosis or trichomoniasis or candidiasis. Most probability is for bacterial vaginosis. Then for the color code kits, kit 1 to kit 7 also they ask a clinical question. Okay. So this you already know. So I just switch over to the next part. 43-year-old female presented with heavy painful periods. For last 8 months, uterus is enlarged 12 to 14 weeks and tender and adnexis free. Adnexis free, that means it is not endometriosis. It is not irregularly enlarged uterus, so it is not fibroid. So this is a clear and straightforward history of adenomyosis. Yes, Amsel's criteria, very commonly they ask for bacterial vaginosis. Very correct, Dr. Alia, absolutely correct. Okay, so this is adenomyosis. Adenomyosis is also quite frequently asked. Okay, in this image of ultrasound, if you are given a question and image, you just see very carefully this is what is the endometrium, and if you very clearly able to trace out, you can see the margin, this is uterus, and you can see so much thick distance of myometrium. So this is myometrial hyperplasia. Myometrial hyperplasia, and you know, like it is quite thick. So this is an image showing adenomyosis. When a question is given and an image is given, you should be able to correlate. So this is adenomyosis. So these are the various, this is MRI scan which is showing that adenomyosis, this is a specimen and this is the histopathological finding. So most of the cases we might have to go for hysterectomy because symptoms are usually not get sorted out with the medical management. What is the most dangerous type of ectopic pregnancy? Just quick recap of rest of the gynae part, then I'll switch over to the some part of important discussion of obstetrics as well. So what is the most dangerous type of ectopic pregnancy? Always remember interstitial. Okay, interstitial, because that part grows in the uterus and it might be taken up as a uterine pregnancy, and this part is very vascular. So if it ruptures, it can cause a life-threatening bleed as well, and this type of pregnancy can continue up to 3 to 4 months before it ruptures. Okay, so cases have reported where the patient's life-saving hysterectomy has been done for an interstitial ectopic pregnancy when it ruptures. So dangerous type is the interstitial type of ectopic pregnancy because it can cause shock, hemoperitoneum, etc. Now this image, what I want to show it here is ring of fire sign in the adnexa. This is a Doppler ultrasound image, and if in the Doppler ultrasound or the transvaginal scan it shows a gestation, see this, you know, patient presents with amenorrhea, bleeding and pain. you suspect it to be a case of ectopic pregnancy, and transvaginal scan is the best non-invasive investigation to pick up ectopic pregnancy. If you find a gestation sac in the adnexa and a cardiac activity, then it is confirmatory. If you have a facility and you are getting a Doppler done, there is a ring of fire sign, that is confirmatory for ectopic pregnancy. Now, let us just quickly go through the criterias, just name the criterias because such questions were asked in JIPMER PG exam. Now, it is INI-CET exam. So, just write down what are the criterias for ectopic pregnancy. Ovarian ectopic pregnancy, the name of the criteria is Spiegelberg. For abdominal ectopic pregnancy, primary abdominal, it is Studyford criteria, and for cervical ectopic pregnancy, it is the Rubin's criteria. So, these three are important part. That ovarian ectopic, it is Spiegelberg criteria. For primary abdominal ectopic, it is Studyford, and for cervical ectopic, it is Rubin's criteria. Got it? Yes. I can see Dr. Alia writing Spiegelberg and Studyford criteria. Yes. Now, identify these instruments. What is this? This is conventional pap smear. Conventional pap smear. This is Ayer's spatula, and this is cyto brush. Ayer's spatula and cyto brush, and on the right side this is liquid based cytology. So, we collect it with a spatula, and this bottle contains the fixative. Fine. So, what is the fixative for the slide method? When you use slide method, conventional PAPs, so it is 95% ethanol plus ether. 95% ethanol plus ether. Now, I want to add up few things. This is important. Now, we talk about cancer cervix, and it is HPV virus infection, that is 1618, which is the proven cause for cancer cervix. Okay. Now, which type of viral proteins cause viral replication, malignant transformation, and which viral particle is being used for HPV vaccination? This is very, very important. Now, even E2 proteins are for viral replication. You can see in this image. Okay. This DNA virus gets incorporated into the epithelial cells of the cervix, and 99% the body clears out this infection. 1% if it persists can cause carcinomatous changes. So, even E2 proteins are for viral replication. E6, E7 is for malignant transformation, and which is dysplastic and later on changes to cancer, and L1 protein, the vaccines are being prepared. So, these are three important questions for your various PG entrance exam which you are going to write. So, remember E1, E2 for viral replication, E6, E7 for malignant transformation, and L1 protein is being used for the vaccine preparation. This is important, and just remember this. Now, HPV names, the low risk viruses are 6 and 11, which cause genital warts and condylomas. Very commonly these questions are being asked, and HPV 16, 18, 31, 33, 45, 52 and 58 are high oncogenic potential viruses which are known to cause or risk factor for cancer cervix, vulva and vagina in females, oropharynx, penile cancer and anorectal cancers. So, this is something, a very, very fast recap. This I have just mentioned it. Now, HPV vaccination, you should know about the Gardasil, you should know about Gardasil 9. Gardasil 9 is nonavalent vaccine. It is nonavalent vaccine which is against containing the strains 6, 11, 16, 18, 31, 33, 45, 52 and 58. And the best time for vaccination is 11 to 12 years. WHO recommends 9 to 26 years of age, and the best or the ideal time. Why 11 to 12 years is an ideal time? Because this time the immune response to an antigen is very good. Okay, so just remember, yes, Cervarix, like nowadays is not very commonly available because I am working as a gynecologist in one of the reputed cancer institute of Delhi. So we are very much following the Gardasil and Gardasil 9. It's available. The cost is, like difference Gardasil 9, 3 doses and cost of 1 dose is around 10,000. Okay. And Gardasil, which is a quadrivalent vaccine, that is cost of 1 dose is 3,500. Okay. So cancer prevention, the best one is the vaccination. Okay. Screening, this is very, very important. Yes, before the sexual activity starts. Now, just remember, this is very important because I am working in a reputed cancer institute of Delhi. So I can just tell you, because so many CMEs and all we are attending and we are giving awareness and talks and all that. So this is very, very important for you to know. This is very important for your upcoming exam as well. Why cancer cervix is unique? Because this is the only cancer where we know the causative agent, that is HPV 16 and 18. This is the only cancer where vaccine is available, and this is the only cancer where WHO claims to eradicate by 90-70-90 policy. What is this 90-70-90? 90% of the girls in our country must be vaccinated, 70% of the females should be screened, and 90% you should get detection and treatment of the cancer. Okay. Alarming data is every 8 minutes, 1 female death is occurring in India due to cancer cervix. So daily 200 female deaths are occurring due to cancer cervix. So cancer cervix, lot many questions, lot many things can be asked. So this I have told you, cancer eradication 90-70-90. Just remember, this is very, very important. Dosage schedule, bache, is 0 dose, 2 and 6 months intramuscular for Gardasil vaccine, and we are vaccinating the girls and boys both because this is a sexually transmitted virus. There is only one cancer where vaccine is available, so you must get yourself vaccinated. So this is the schedule. Like 0 is today you have applied, got a vaccine, then 2 months later and then 6 months later. This is the dosage schedule. Now something about dysplasia. Now, what are the screening methods for dysplasia cervix? You should know pap smear, HPV DNA and VIA, that is visual inspection under acetic acid. Now, WHO says the best screening method nowadays is HPV DNA testing, and we are doing in our hospital by the gene expert method. Okay, although the cost of getting the HPV DNA is around 3,000, and when you should start, like screening with, like why I am not saying pap smear. Pap smear has been done, okay, where there are resource limited countries, but pap smear needs to be confirmed on colposcopy. If it is abnormal pap smear finding, you cannot offer treatment, you have to go for colposcopy. Whereas HPV DNA, you can go for further VIA testing or a TRIAS testing in resource rich countries. So age group to start the HPV DNA is 30 years. It is not recommended. If it is coming negative, then every 10 yearly HPV DNA can be used as a primary test. Where cost effective if you talk about according to mass screening by WHO, then it is VIA, visual inspection under Lugol's iodine. Okay, pap smear can be done as early as 21 years of age in a sexually active female. Okay, so these also terms you should know. Co-testing means HPV DNA plus pap smear to be done together. Reflex HPV means there is abnormal PAPs, you are doing HPV DNA. These terms are important. Cytology means pap smear test, and triage means pap smear, HPV DNA, and VIA. And there is a facility for colposcopy. Yes, all of you are writing very correct answers in the chat box. So, co-testing, reflex HPV DNA, then cytology and triage testing, you should read this for when you are aiming at the PG entrance exams. This is very, very important. This is according to FOXY GCPR guidelines. This slide is very, very important. Now, I would like to take this question. 30-year-old female came with gynae OPD with the complaints of vaginal discharge and no evidence of genital ulcer, no abdominal pain. Which color kit you are going to provide? So, vaginal discharge means vaginitis. For vaginal discharge, which color code kit you are going to give? Which color code kit you are going to give for vaginal discharge? That is vaginitis. So, your answer is green. Okay. So, please go through this color code kits. Gray is for cervicitis, green is for vaginitis, which contains sacnidazole and fluconazole. Herpetic ulcer is white. Allergic to penicillin, then it is blue. If it is, like herpetic ulcer, non-herpetic, it was white and blue. Herpetic ulcer, it is red. PID is yellow, pelvic inflammatory disease, and inguinal buboes, it is black. So, please do remember this color code kits. If it is INI-CET exam or it is NEET PG exam, this is very, very favorite question of reproductive tract infection color code kits. So, I am just switching over to the obstetrics. Some part of important concepts of obstetrics also I have to discuss, and I am just starting up with a question that is, DIPSI criteria, Diabetes in Pregnancy Study Group of India. Okay. According to this national guidelines, universal screening for gestational diabetes to be done in all pregnant ladies. You have to tell me there are 2 times the testing is recommended. Number 1 is at the first antenatal visit. First is first antenatal visit. Okay. Number 2, it is to be repeated at 24 to 28 weeks of pregnancy. Why? Because at this time insulin resistance is high. Okay. So, it is better to repeat the test for screening of diabetes in pregnant ladies. So, first antenatal visit and then repeat at 24 to 28 weeks of pregnancy. Yes, very correct. Very correct. So, any fasting needed? No. No fasting is required for doing a universal screening for gestational diabetes. Okay. Now, according to DIPSI criteria, how many grams of glucose needed? Remember, 75 grams of glucose. Okay. Previously, according to glucose challenge test, it was 50 grams of glucose and the blood sugar was checked after 1 hour. Now, nowadays, according to DIPSI criteria, 75 grams of glucose is given and the blood glucose levels are checked after 2 hours. The cutoff value is less than 140 milligram per deciliter. So, the cutoff value, many times they have asked a question. Now, again one more important question they have asked, according to International Association of Diabetes in Pregnancy Study Group criteria, they say 75 grams of glucose you should give fasting sample 1 hour, 2 hours. So in AIMS PG exam, they have asked the cutoff values. So what are the cutoff values? Fasting is, it should be less than 92 milligram per deciliter. 1 hour should be less than 180 milligram per deciliter, and 2 hours less than 153. So what you should remember is DIPSI criteria, how much amount of glucose, and is fasting needed? No. Sample collection to be done after 2 hours, and the value cutoff should be less than 140. Now, according to International Association of Diabetes in Pregnancy Study Group criteria, 75 grams of glucose to be given, fasting 1 hour, 2 hours value you should remember, 92, 180 and 153. Then, this is again an important question, image based question. The image they have given and they have asked that what is it associated with? Gestational diabetes, pre-gestational diabetes, phenytoin or steroid in the first trimester. What is your answer? I can read your correct answers for the DIPSI criteria as well as IAP, International Association of Diabetes Study Group criteria. I can read Dr. Fareen, Dr. Puri, Dr. KK, Dr. Karthik, Dr. Wahid. You have all written it correctly. Now, what is the answer to this question? What do you see? This is caudal regression syndrome. Caudal regression syndrome, which is very, very suggestive of pre-gestational diabetes, which is very, very suggestive of pre-gestational diabetes. So, this is very clear cut straightforward answer. Fine. Next, identify this image. This similar question has already been asked in AIMS PG, and I am expecting a question might be asked in INI-CET exam. Identify what is being done in this image. This is an image of a pregnant lady, and what does it show? Excellent, Dr. Puri. This is NST, which is non-stress test. You check the fetal heart rate, okay, and in relation to fetal movements. That can be checked as a part of biophysical profile by ultrasound, or it can be checked by NST machine. Okay, so when the lady is not in labor, NST is done, and you check the parameters like baseline fetal heart rate, which is between 120 to 160 beats per minute. Number 2, you check beat to beat variability. Number 3, you check for any acceleration, and there should be no deceleration. So these are the 4 important findings you check, and this is NST machine non-stress test. Okay. Now this is reactive NST. Can you see? This is the fetal movement. The lady is supposed to press the button on the belt. You have taken the basal fetal heart rate, and you can see this is a reactive NST because you can see the baseline fetal heart rate is around 130. Then you can see the acceleration of the fetal heart rate. You can see the beat to beat variability. So this is a reactive NST. Okay. Now identify what is being done. When you see 2 probes, this is CTG, cardiotocographic monitoring. That means relationship of fetal heart rate to uterine contractions. So when you see the graph, these are uterine contractions, and this is the fetal heart rate pattern. So this is what is a normal CTG trace. So CTG is different from NST. if image based, there are two probes. One is recording the uterine contractions, next is recording the fetal heart rate pattern. Okay, in the previous image there was one probe, so that is for NST. NST is done when the lady is not in labor. CTG is done to check the relationship of fetal heart rate to uterine contractions. Now this is a sinusoidal pattern on CTG. When do you see the sinusoidal pattern? Sinusoidal pattern, this pattern is fixed. This is when there is a fetal anemia or there is a fetal hypoxia, like in case of vasa previa, twin transfusion syndrome, or intracranial hemorrhage, or RH isoimmunization. So sinusoidal pattern is seen whenever there is a fetal anemia which is severe, or hypoxia. That can be vasa previa, that is a type of antepartum hemorrhage where the blood is fetal in origin, or it can be twin transfusion syndrome, or there can be intracranial hemorrhage. So you see this sinusoidal pattern. And what is the management you should know? The management for sinusoidal pattern on the CTG is a cesarean section. Now late deceleration. What is late deceleration? Late deceleration is a feature of chronic placental insufficiency when there is hypoxia. Now why there is hypoxia? Because of preeclampsia, because of chronic hypertension, etc. Okay. So you see the dip of the fetal heart rate starts after the uterine contraction is over. So that is how you are going to identify the image. Okay. And the dip of the fetal heart rate should be persisting for more than 30 seconds. So management of such a finding is, like you have to go for a cesarean section. Now identify this maneuver. This is very commonly asked, and it is one of the favorite question for AIIMS PG. These maneuvers have been asked. They can take just one image out of this. They have asked this image and they have asked what is this grip. So first grip is the fundal grip. Second grip is the lateral grip. Third grip is the pollic grip, and fourth grip is the pelvic grip. When you apply these grip to find out the lie and presentation, this maneuver is called as Leopold's maneuver. This maneuver is called as Leopold's maneuver. So first grip, fundal grip, second grip, lateral grip, third grip, pollic grip. Pollic grip is for presentation. Pollic grip is for presentation, that is cephalic presentation or it is podalic presentation. Fourth grip is pelvic grip, is for engagement. So remember the name of the grips, first, second, third and fourth. They can give you just one grip or they can give you this whole maneuver, then that is called as Leopold's maneuver. All of you are correct. Dr. Payal, Dr. Goel, Dr. Wahid, Dr. Karthik, okay, Dr. Rajat, everyone is correct. This is Leopold's maneuver. Okay. Identify what is being shown in this image. This was a very important question of DNB pattern exams, and it has been asked even in the AIIMS PG exam as well. What is, identify this, what is this showing in this image? So in this image, a diagonal conjugate is being measured. Diagonal conjugate is being measured. This is the only conjugate we measure clinically. Okay, this is for the inlet. Okay, we try to touch the sacral promontory, but normally it is not felt. Then we raise our finger till the finger touches the symphysis pubis. So we mark the tip of the finger with this point, and this is what is a diagonal conjugate. Diagonal conjugate is nearly 12 centimeters. If we find out the diagonal conjugate, we can subtract 1 or 2 centimeters to find out the anatomical conjugate or the obstetrical conjugate. Fine. Now, This is the 4 types of pelvises. Now my question is, what is the most common type of pelvises in the female? Most common type of pelvises among the 4. So answer is most common type of pelvises in most of the female is gynecoid, where the cavity is circular. Now my next question is, occipito-posterior is seen in which type of pelvises? So answer is anthropoid and android pelvises. Now my next question is, which of the 4 pelvises the deep transverse arrest can occur more commonly? So the answer for deep transverse arrest is android pelvis, where it is called as male type of pelvises, and like the occiput rotates and get arrested at the level of ischial spine. So this is called as deep transverse arrest, and the management, deep transverse arrest occurs at 0 station, that is at ischial spine, and in modern times the management is emergency cesarean section. Now what type of forceps was used for deep transverse arrest, which is obsolete now, is keel end forceps. Nowadays it is no longer used to extract the baby in cases of deep transverse arrest. Now face to pubis delivery is seen in which type of pelvises? So answer is anthropoid type of pelvises. Anthropoid pelvises, you can see the transverse diameter is shortened. So deep transverse arrest can occur in anthropoid pelvis as well, but face to pubis delivery typical is a feature of anthropoid. Deep transverse arrest is a feature of android pelvis. Now which type of pelvis is where occipito-posterior rotates and delivery can occur? So answer is gynecoid pelvis. So this is very, very important. Okay, most common pelvis is gynecoid. Rotation is possible from occipito-posterior to occipito-anterior, that is gynecoid. Then deep transverse arrest, android. Face to pubis delivery, anthropoid. This is something which is important. Will you do a cesarean section for occipito-posterior? No. You give a trial of labor. Most of the cases the delivery occurs, but their stages of labor are delayed. So observation is very important. But if there is a possibility that occipito-posterior arrest is occurring, or like there is a fetal distress, or there is a deep transverse arrest happening, then it's better to go for an emergency cesarean section in time. Now identify the types of forceps. You can see a screw and an access traction is being applied. This was a Das forceps, which contains long forceps with access traction. This is no longer used. This is short curved forceps. This is Wrigley's forceps, which is an outlet forceps. This is used, Wrigley's or outlet forceps. Now this is the correct position of the forceps. It should be equidistant from the sagittal sutures, and application is on the occipitomental direction. Now the sutures, this is the vertex presentation. Sometimes they can ask the boundaries of the anti-A fontanelle, what are the boundaries of the vertex presentation, etc. So you should be knowing. And one important reason for keeping this image in this session is I want to tell you where do you apply the vacuum cup in case of vacuum extraction. In case of vacuum extraction, what is the point where you apply the vacuum cup? So answer is 3 centimeters anterior to posterior fontanelle. 3 centimeters anterior to posterior fontanelle. Okay, that is the level where you apply the vacuum cup. What is the vacuum pressure? Vacuum pressure is 0.8 kg per centimeter square. What is the absolute contraindication of vacuum extraction? Is prematurity and non-vertex presentations. Prematurity and non-vertex presentations are the absolute contraindications for vacuum extraction. Now, BRAW presentation. I have just added this slide just to make you understand what are the boundaries of BRAW. BRAW is this part. The boundaries of BRAW is coronal suture and anterior fontanelle and supraorbital ridges. So, they are not going to give you the skull image, they are going to ask you about this presentation. So, students get confused. See, occiput is posterior, so it cannot be a vertex presentation. Mentum is again behind the pubic bone, so it is not a face presentation. What do you see here? So, this is an image of BRAW presentation. So, they are not going to give you image of skull, but they are going to give you image like this, and they can ask you about the presentation, if not in INI-CET but might be in the NEET PG entrance exam. This is not face, this is BRAW presentation. Now, how does a face presentation look like? Face presentation, the boundaries are supraorbital ridges and junction of floor of the mouth with neck. Okay, so you can see the mentum anterior, you can see the occiput posterior, and you can see this face is coming anterior. So, this is a face presentation. Okay, so that is how you are going to identify the images. Fine. Now, what is this maneuver shown here? You can see the placenta and there is a suprapubic pressure being applied. So, this is to extract the placenta by controlled cord traction method. To extract the placenta by controlled cord traction method. Now, this is an important question from INI-CET exam, and maybe the options looks quite lengthy to you, but you can, once you get hold of the exact sentence or the words, you will be able to get the correct answer. Now, they have asked about magnesium sulfate for pre-eclampsia and eclampsia. It has been an anticonvulsant that you know. But does it lower the blood pressure, or is it the drug that is used to lower or to as an antihypertensive? No, it never lowers the blood pressure. Okay, so this is the answer which is incorrect. Now, let us read next options. Magnesium sulfate quietens the uterine activity. Yes, that is why it is a tocolytic agent. Okay, although the best tocolytic agent we use is nifedipine. First line tocolytic agent is nifedipine. Okay, next. So, this is correct answer. Maintenance dose is given 24 hours of last convulsion or 24 hours of delivery. This is also true. Magnesium sulfate is entirely excreted by the kidneys. This is also true statement. So, wrong statement is it does not lower the blood pressure. It is not antihypertensive. Next. All of the following are the causes for non-immune hydrops fetalis. Now, first of all, just tell me basic thing. What are the causes of immune hydrops fetalis, or what do you understand by immune hydrops fetalis? Immune hydrops fetalis is the antibodies are formed against the antigen which can cause hemolysis. So, there is generalized anasarca, pleural effusion, pericardial effusion. So, the important cause for immune hydrops fetalis is blood incompatibilities, which can be RH or ABO incompatibility. And non-immune hydrops fetalis, you know, the torch infections, or there can be congenital heart disease, arrhythmias, or there can be alpha thalassemias, or there can be Turner syndrome, there can be trisomies. All these are the causes for non-immune hydrops fetalis where there can be a chance for bone marrow suppression. Okay. Now let us just read the options. ABO incompatibility, parvovirus B19, thalassemia, sickle cell anemia. This is recently asked question of INI-CET exam. Okay. So what will you mark in the answer? Yes, I can read Dr. Payal, Dr. Joshi, Dr. Anshika. It is very correct. ABO incompatibility is a cause for immune hydrops fetalis, whereas parvovirus B19, thalassemia, alpha thalassemia and sickle cell anemia are the causes for non-immune hydrops fetalis. Fine. So this is the image of the hydrops fetalis. Now, pudendal nerve block. They can give you this image and they can ask you about this. So you can see in the bone, this is the level. They are not going to mark you, mark this ischial spine and all. So which is the level where you give the pudendal nerve block, that is ischial spine. Okay. Next, important question which they want to ask is, which is the ligament pierced while you are giving the pudendal nerve block? So the answer is sacrospinous ligament. The ligament pierced during the pudendal nerve block is a sacrospinous ligament. This is important question. Fine. Now, what is the level of block while you are doing a cesarean section? You want to give spinal anesthesia or epidural anesthesia. So answer is T4 level below. There is anesthesia. So level for this is T4 level. While you are giving epidural analgesia, that is painless delivery. This is anesthesia and this is analgesia. For painless delivery, the level of block is T10 onwards. That means the lady should not feel the pain of uterine contractions of cervical dilatation and the uterine pain. The nerve roots are T10 to L1. Nerve roots are T10 to L1. Now, partogram. There are 4 components of partogram: maternal information, fetal well-being, labor progress, IV fluids and maternal well-being. So this you must be familiar with the components of the partogram. The information is the maternal information. Then next is a column for fetal well-being where there is a fetal heart rate. Then there is amount of the color of the liquor. Then there is cervicogram where there is an alert line and action line. Then there is uterine contractions, IV fluids and maternal parameters. Fine. Now, plotting in the partogram. How frequently you should be plotting the fetal heart rate? In the first stage of labor, you are plotting the fetal heart rate every 30 minutes. In the second stage of labor, you are plotting the fetal heart rate every 15 minutes. This is important. They have already asked about the first stage. The pulse rate you are going to plot every 30 minutes, the blood pressure every 2 hours, temperature every 4 hours, uterine contractions every 30 minutes, oxytocin findings, if you have started the oxytocin drip every 30 minutes, time for plotting the partogram 30 minutes per vaginum examination every 4 hourly. Most of the time they ask you about the fetal heart rate. Okay. Now, from this partogram, what do you find? This is a normal progress of labor. They can give you a statement or they can ask you in the image, just like comment upon the finding. So you can see the fetal heart rate is not dipping to just less than 100. When we take an image and we just post it, like sometimes the pixel gets broken, so that is why sometimes the image is blurred, but when you get in the exam it's very clear. Okay, now you can see there are 3 zones: zone 1, zone 2 and zone 3. So the above line is the cervical dilatation, and the plotting in WHO modified partogram starts from 4 centimeters of cervical dilatation. Okay, then next line is the descent of the fetal head, descent of the fetal head. So on the x axis you are plotting the time in hours, that is every 4 hourly. Okay, and in the y axis you are plotting the cervical dilatation and descent of the fetal presenting part. So in this case your curve for cervical dilatation should be left of the alert line, that is in zone 1. Now next column is for uterine contraction. It is dot dot dot, that is mild contraction. It is line line line, that is moderate, and if it is just a black, that means it is good uterine contractions. Okay, so that is how you are just looking into the partogram and you are able to answer. Let us see this. This is very clear cut image where descent was not occurring, then an intervention was done. Can you see 10, 30, 45, what is this? They have added the oxytocin, because from zone 1 the plotting was going in zone 2. Zone 2 is means that the progress was slow progress. So the oxytocin was given, which increased the uterine contraction. Can you see dot dot to line, from line to block, dark black, that means oxytocin was given, so good uterine contractions. So from zone 2, before it goes to zone 3, you have given oxytocin, so descent of the fetal head occurs, cervical dilatation is full, so baby has delivered. So this is a normal progress. Now can you see this? This is showing arrest. There is no descent of the fetal head, because you can see the weight of the baby was 4.6 kg. It should have been an elective cesarean section. So this was a case of CPD or contracted pelvis, where somebody has done a very wrong judgment to allow this patient. So she has gone into obstructed labor. Fine. So it will be a clinical questions which is going to be asked. Now identify this instrument. This is Cocker's artery forceps. This is used in obstetrics for artificial rupture of membranes, and in gynae it is used as a clamp while you are doing salpingectomy in cases of ectopic pregnancy. You are doing oophorectomy for any cases of ovarian cysts. It can be used as a clamp in cases of gynae, and it is used for rupturing the artificial rupture of fetal membranes in cases of like abruptio placentae or post-dated pregnancy, etc. Now this is the image of the monozygotic twins. This is diamniotic dichorionic. This is diamniotic and monochorionic. This is monoamniotic and monochorionic. You can see there is a single amniotic sac and there is a single placenta. Here you can see 2 amniotic cavities and a single placenta. Here you can see 2 amniotic cavities and 2 placenta. So chances of survival is better when there are 2 different chorion. Fine. Now lambda sign. is seen in dizygotic twins and T sign is seen in monozygotic twins. Chorionicity scan in cases of twin pregnancy is done at what particular gestation, which is the best time to do a chorionicity scan? This is an important question. What will you mark? What will you mark for this question? Chorionicity scan, that it is dichorionic twins or monochorionic. So the answer is correct answer is the correct answer is 10 to 14 weeks. So chorionicity scan should be done in less than 14 weeks. So best time for chorionicity scan is 10 to 14 weeks, and best time to diagnose twin pregnancy by ultrasound is 10 to 12 weeks time. 10 to 12 weeks time. Now trap twin. What is a trap twin? Trap twin is, or acardiac twin, that there is a amorphous mass and the baby who is normal, his heart is pumping out his own blood, and the another baby which is just a mass, the upper part of the body is absent. So the baby which is normal with a heart, this is called as pump twin, and chances of death for this baby also occurs because it is taking the overload of the second baby which is just a mass. So this is at a chance of congestive cardiac failure. Now just identify these instruments. This is Doyne's retractor. This is to retract the urinary bladder while you are doing the surgeries on the uterus like cesarean section or hysterectomy. This is Deaver's retractor. This is used during the abdominal surgeries when you want to retract the mesentery or the omentum or the liver or the spleen. So this Deaver's retractor is used. This is ovum artery forceps. This is to perform DNE in cases of inevitable or incomplete abortion. Important feature to identify this instrument is there is no lock in this instrument. Okay, and this scissors, they have asked in AIMS PG exam, this scissor is episiotomy scissors. This is episiotomy scissors. So yes, Dr. Sovic has written it very correctly. First one is Doyne's, second one is Deaver's retractor, third one is ovum forceps, and fourth one is episiotomy scissors. Now identify this. This is a green Armitage forceps. This is to hold the uterine angles. If suppose you are dealing with a cesarean section and the uterine angles have gone towards very lateral and where there is lot of bleeding. So to achieve that this incision should not get extended, you can apply the green Armitage forceps and then you can start the stitching after the baby and placenta has been delivered. So this is green Armitage forceps. Now identify this. This has already been asked in the PG entrance question. This is Leash-Wilkinson cannula. Leash-Wilkinson cannula. This instrument is used while you are performing hysterosalpingography. You have to inject the dye into the uterus, so you have to cannulate the cervix with Leash-Wilkinson cannula and you can perform the hysterosalpingography. Next is, there are two questions which I have written. A baby born very pale to a mother who had history of antepartum hemorrhage. Name the type of placenta responsible for this condition. You have to tell me the name. And second question is, a lady presented with excessive bleeding after 48 hours of delivery. Name the type of placenta responsible for such condition. Now, number 1, the answer is filamentous insertion of placenta, and that is this one, where you see the umbilical cord is attached to the fetal membranes. So, there will be laceration of these membranes and there will be bleeding, and the bleeding is a fetal origin. The blood is fetal in origin, that is why the baby is born very pale. Now, next question is a case of secondary PPH. Such questions have been asked in AIMS PG, and this is suction curita lobe. This is suction curita lobe, that is this image. Now, what is the definition of secondary PPH? Postpartum hemorrhage occurring after 24 hours of delivery up to 3 months of delivery. That is the definition of postpartum hemorrhage. Students just write purpurium, but that is wrong. It is after 24 hours of delivery, within 12 weeks of delivery is the definition of postpartum hemorrhage. Fine. Secondary postpartum hemorrhage. So, filamentous insertion and suction curita lobe. Now, an intern conducts a delivery. Immediately the mother experiences the breathlessness, hypotension, tachycardia and collapse, and there is no excessive blood loss. Now, tell me, what is this condition? So, when there is no excessive blood loss, this is not postpartum hemorrhage. DIC never presents like this, and like it's not uterine inversion. It is, because uterine inversion will be when the shock is out of proportion of blood loss. Out of proportion of blood loss, then that will be acute inversion. So, this answer to this question is amniotic fluid embolism. Yes, Dr. Goel, Dr. Abhi, Dr. Rajat, Dr. Somik, you have written it very, very correctly. Now, identify this. Now, this is again a question of INI-CET, because I want to just give you a clarity. Please do prepare such type of questions. For this, your concepts has to be very clear. Very excellent replies I am getting from the students. For breech, it is Prague's maneuver. For shoulder dystocia, Macrobert's maneuver. For normal delivery, Ridgen's maneuver. For lie and presentation, Leopold's maneuver. So, breech is Prague's, A is for, 1 is for B, 2 is for A. So, the answer is C, which I can see very quickly students are writing. Dr. Somik, Dr. Abhi, Dr. Goel, Dr. Rajat. Dr. Rajat, you have written it correctly. It is C. Okay? Yes. Now, this is Ridgen's maneuver. You can expect such question in your exam. Okay? Now, cancer caused by DES exposure is a question of INI-CET. So, I am giving you a very good preparation. So, this way you should prepare for your INI-CET exam. So, I am just giving you a good practice of questions, images, instruments, single liners, concepts and tricks how to solve the questions of OBS Gynae very correctly. So, I am just almost on towards the concluding of this session. So, just tell me, what is the answer? Yes, Dr. Somik, you are excellent. Dr. Payal, this is clear cell carcinoma. Just do revise this slide. DS exposure in males leads to, if it's a male fetus, then it is undescended testis, phimosis and male infertility. In the female, malignancy like clear cell adenocarcinoma of vagina and cervix. Abnormalities like T-shaped uterus, Coxcomb cervix, fimbrial abnormalities and Escherman syndrome. please do revise this slide, which is very important, and specifically I have added up to give you very clarity of this DES exposure, because not easily students get this content. Okay, just to help you out. Yes, very correct, you're right. Now something about peripartum cardiomyopathy, which is again a favorite question for PGI entrance exams. Now it is INI-CET. It is development of the heart failure in last month of pregnancy or within 5 months of delivery. The cause is not known. The ejection fraction, is decreased to 45%, and there is dilated left ventricle. So the patient has a shortness of breath, cough, nocturnal dyspnea, tachycardia, and pregnancy is very poorly tolerated, because this is usually developing unknown cause, and suddenly there is dilated cardiomyopathy. Treatment is just bed rest, digoxin and diuretics. Now maternal death, what do you understand? What do you understand quickly? I'm just concluding the session. So what maximum practice I could give in this session, I have just tried my best to add up as much as content as I can. Not just discussing 2-3 topics, but discussing plenty of topics in the form of questions, concepts, single liners, images, image-based questions, previous INI-CET questions. So do revise this session, it is very important. So tell me the answer to this question. Yes, you are very correct. Death during pregnancy or within 6 weeks of pregnancy is maternal death. Most common preventable cause of maternal death in India, postpartum hemorrhage. Most common indirect cause of maternal mortality in India, anemia. Now this is what is the LEAP instrument. Okay. So LEAP is a best treatment, that is loop electrosurgical excision procedure. It is the best treatment for CIN2 and CIN3. So friends, I take your leave now. So thank you so much for the wonderful batch of the students. You had been very attentive, and do revise this session. It is very important. So the topics, as much as I can, I have covered it. So all the best for your upcoming INI-CET exam. Thank you very much for your appreciation words in the chat box. Thank you. Bye-bye. And all the best. Thank you so much. Thank you all, and all the best. And what I get my feedback from this session is that wonderful, you have prepared really well. Bye-bye.